And let's start this.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Hello, 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 hello. Hi, gals.
Hello.
Hey,
Hello, Alicia.
how
Hello,
are you?
Jennifer.
Hey,
Hello, everybody out there in webinar land. Boyd here, your CCO team in the webinar chat and going behind the scenes. Welcome to the July 2019 Certification Q&A webinar. How's everybody doing today?
It's
awesome.
hot.
No, it's hotter here. It's hotter here. Nah.
Yeah, you guys got it bad.
Yeah, I think it was up to 102 today, 100 and I don't know, 100 and
That's
something.
crazy for the East Coast, right? Up
Ouch.
north
Yeah,
coast like that. So
Yeah,
yeah.
we luckily got our second AC unit in that's been missing for years after we bought this house. And so it was very good timing. Very good timing. So if you can hear and see us, please put a 1 in the chat in your question box there so we can make sure that we can be seen and heard. That would be awesome. In the background today, we have some people on holidays. Jesus, who's normally kind of hiding, he's in the background here today. So welcome, Jesus.
yeah.
And
Probably
why
not
don't we
gonna
get
say-
going here, Alicia? Why don't you just hit the next slide? I guess we're ready to go.
Sure, okay.
So if this is your first time, welcome to the CCO community. This is a general webinar about all things medical business certification, medical coding, billing, and practice management related. Can they hear us, Jennifer?
Oh, yes,
can we
they
hear them?
can. Seen and heard.
Can we hear them? Skill testing question.
No.
Right. So this is if this is your first time, know that you can always put us a question in the chat there. First poll we want to find out from everybody: what is your status in the medical coding, billing, or similar medical coding job? Are you looking at a medical coding as a career? Are you certified and looking for a job? Are you employed? Or are you improving your current job situation and trying to earn a new credential? Or are you not doing anything that's related to medical coding, billing, or medical business related at this time?
They are hot tonight too. I tell you what, that poll is filling up fast. You guys are on top of it. So we are almost at 70%. You know what? I love doing what Boyd does, and he always counts it down. So I want to count it down. Okay, are you ready?
Yeah.
Everybody get your votes in. 5, 4, 3, 2, 1, and close. Oh, that was good. Okay, let's share it. What do you think? Are you shocked?
Read them off.
So we have 31% that state that they're looking for that medical coding as a career. Only 8% certified and looking for a job. That's really low. 25% already employed. Fabulous. 34% improve my current job situation and earn CEUs. And then only 3% says, nope, not pursuing employment at this time. So that's fabulous. 25% employed and are just coming to see us because they like us.
Actually, it's more like almost 60% because we add improve my current job situation plus employee.
Yeah.
Yeah, you're right.
Well, I love that one. That's so high. That improve their job situation and earn a new credential. That's just
very cool.
That's great.
That's awesome.
It's exciting. Oh, guess what, guys? We have 3 topics each. We have, when Jennifer and I do this together, we've got it down to a science, and we know 3 topics each. Jennifer, what are you going to tell them about today?
Hold on a second. Hide the poll for us because I think.
Did I not hide it? I apologize. No. I apologize. Yep, got to remember.
I do remember off the top of my head though, but but I am going to talk a little bit about medical record retention. So I'm in billing, and I like some of that side of it. So the practice management side, NICU coding, NICU coding for your preemies in this case, or young infants, and the CFPC exam, and I'll explain what that is.
Ooh, so if you don't know, stay tuned. I get to talk about coding SloMo Surgery. Actually been around for a while, but you may not have heard of SloMos. And then we've done a lot of stuff on STEMI and non-STEMIs, but this person had a unique question. So myocardial infarction STEMI versus non-STEMI coding, and then taking the CPC exam again. A person had asked a specific question about, hey, she's taken it, and kind of the steps for retaking. So it'll be fun. It'll be fun. Got some heavy stuff, and we got a little bit lighter stuff tonight.
Nice. So please stay to the end. I switched the questions around. Normally we find out by now how many people are new for the first time. So if this is your first time, we're going through prepared Q&A questions that have already been submitted. So we have some time to prepare for those, because we all know that some of these questions are pretty involved sometimes, and they don't get answered in about 2 seconds that sometimes people are looking for. At the end, we're going to draw for a prize for those of us who are still attending. And then we're going to always throughout the webinar, we're gathering your questions, and then we're going to put those the ones in the end after about 9-ish, 9:30-ish, right? And be able to answer those ones that we can at the end. And if not, we'll add those to our roster for the next time. All right. So welcome, Baton Rouge. Just checking in there. Hello, Susan. Welcome.
Yay.
And again,
so if you do
go ahead.
Stay till the end, we've got an excellent giveaway. Now, some of you guys that have been with us before, you're familiar with our giveaways. You can either get a Blitz video package, you can get an hour session with one of us, or you can get a year of the CCO Club Basic, which in my opinion is the most fabulous of the three. However, it's all up to you. So make sure you stay till the end. Do you want me to tell them about CEUs, or do you want to tell them, Boyd?
Go ahead.
Okay, well, you know what? If you need CEUs, we're here for you. I kind of feel like I'm a commercial. We're here for you. So some of the ways that you can get CEUs through CCO is you can do the webinar and supports. Webinar like this. We do billing and coding Q&As. We do webinars throughout the whole week, and we have extended product support. So if you want to know more about getting CEUs, you can go to the CCO.US/club, and right now there's 80 CEUs in there, which again, there's a lot of FAQs on that club page, so it should be able to answer any questions that you have. It's a real exciting place to be anyway. Oh, guess what time it is?
Yay!
Graduate time. Do you want to take the first page, Jennifer, because there's 2 pages?
Oh, awesome. Yep.
Okay, so make sure you let us know if you've recently passed one of the exams, and especially if you've used one or many of the products that we provide. Let us know, and it's an easy way to do that. Just go to the CCO.US/, because I usually say backslash, and then I was corrected. Pass the exam with the hyphens. Oh, right. Now, this time we don't have last names. I don't know why they didn't put them in there, and it could be that they didn't give us permission or something, but just so you know.
Okay. Well, first we have Michelle, who passed her CPC in June. Anne Marie, also the CPC in June, as well as Luann did the COC in June.
Wow, look at all those products that Anne Marie used. And then it looks like we have the CPB, which is a billing course. Paul, and then, oh my word, I should have given you this one. We have 2 people that passed the CRC, and I don't know if I can say that name, but is it Bakhtihar? Let's see, Yuzopov? What do you think? That looks pretty close. CRC. And then Tammy Seaborn got her CRC. Yay, Tammy. I know Tammy. And then Shirley Grissom got the CPMA, which is the auditing course. So the auditing credential. Thanks, guys, for letting us know.
Sorry,
We're
my
ready.
daughter's taking off on vacation for 10 days, so I had to tell her goodbye real quick. So.
We have that happening in our house too. I get the whole week to myself with no kitchen because we're rehabbing. Anyway, so
I have to tell you, was it last Wednesday that we were all like our kids just kept going in and out? We never have that problem, and then it was all 3 of us. Okay. I'm sorry.
Welcome
Go ahead,
to
Boyd.
the Q&A portion. We're going to go over through 6 questions today, starting with our dear Jennifer, who's going to be talking about CFPC exam information.
So we had a question come in asking just a little bit more information about the CFPC. And I just kind of jumped at this one because I actually had 2 members in my chapter who have been steadily trying to pass this exam. So I just thought, okay, well, I'll take this one then. So the CFPC is a credential through AAPC, as most of them are out there. It is for a certified family practice coder. So it's specifically dealing with family practice. It could be for, internal medicine, sometimes anything in the primary care arena. So you might be dealing with pediatrics, you might be dealing with internal medicine or family practice. I used to work in this field as well, and you see everything comes in through here. So everybody goes to their primary care doctor for just about any reason whatsoever. So what's this test include? Now, normally the AAPC gives a listing, like if you were to look up the CPC or the COC or some of the other exams, they'll tell you 10 questions are going to come from this, 15 questions will come from this. The CFPC didn't do that. So what they do is specifically say these are what you're going to be tested on. So what kind of skills are you going to need to know? So you're going to have to abstract an office note, and remember, this is a primary care office. So you're not dealing with those complex cardiology notes or like what I deal with, orthopedic surgery. You're not dealing too much with that. You're dealing with office notes. So you're pretty much looking at your ICD-10-CM, a CPT and HCPCS. That's what they're going to want you to abstract from some of those notes. But however, what do they do a lot of in family practice? Evaluation and management, a lot of office visit codes. So you're going to have to look at both the 95 and the 97 guidelines. And usually when they give you a question like that on a test, they're going to say, using the 97 guidelines, how would you rate this level? So you're going to be looking at that, determining that level of history and that medical decision making, which we do a lot of webinars on. So if that's tough for you, try and look some of those up. And what is the appropriate service level for the service that was provided? So a lot of times people have problems with this E&M. So this is one area that's going to be on the CFPC. Normally in any of the CPC exams or something like that, they're going to say you had a problem-focused history and a comprehensive evaluation, so rate your level. So that's a little bit easier because those are laid out for you in the CPT book. It will just give you the description of problem-focused or brief or comprehensive, where in this case, you're going to be actually saying, wow, there's 4 criteria points here for history, so that puts it at this level. The medical decision making is low or high, so that's going to be this level. So it's a little bit more involved. You're going to have to know those Medicare rules, such as Incident 2. Incident 2 is used a lot in a family practice setting because you might have nurse practitioners or physician assistants who are also employed in that office. So you need to know some of those rules. Incident 2, shared visits, sharing between the nurse practitioner and another provider. Consultations, hint, hint, Medicare consultations, can't use them, but you're going to be going on what are those codes for consultations. So if you can't build a consultation, what do you do? And as well as some surgical global criteria. So they do some minor surgeries in a family practice setting. And they also do ancillary services, venipuncture, EKGs, injections, some kind of minor services. Sometimes they do hydration in a family practice. Sometimes they do nebulizer treatments. So there's a little bit different things that might be involved in a family practice setting. Your minor surgical procedures, excisions, removals, incision and drainage, foreign body removals, things like that are done. You go to your family doctor. I mean, took my daughter to the family doctor for a tick in her belly button, so removing a foreign body. They might do some time-based services. Some family practice offices might deal with modalities for some reason. Those are time-based. And of course, your terminology and anatomy and physiology, the standard questions. So it doesn't break down, you're going to have 45 E&M questions and 10 anatomy questions. You're going to be tested on all those areas. So like all the other exams, it is 5 hours and 40 minutes for 150 questions. So that's good to know ahead of time. But unlike some of the other exams, CPC, you can take in your ICD-10, your CPT, and your HCPCS. That's it. Well, you get to take those 3 books as well as those 95 and 97 guidelines. Those can be printed out. You could bring those with you. An E&M scoring sheet. There usually has a couple that come in the test book, but you could bring your own. You could have it laminated, and that way you just use an expo marker or grease pen, and just write your answers off. If you do fill in any of those sheets of paper, you have to turn those in along with your book as well. So that's why if you use the white off one, you can take that information off, or even just put in a sheet protector and using an expo marker works the same way. You also get to have an additional reference of your choice. Of course, that can't be a study guide. It can't be, certain books are not required in there, but medical dictionary, a terminology. There's some of those coding, maybe you want to have the NCCI or some kind of coding. I can't think of the name off the top of my head, but there are multiple books you can choose to bring in with you, whether you need them or not. You could probably question somebody who might have taken that exam before to see what reference they used and if it even helped them at all. You don't have to be a CPC or a CPB or anything like that before you take the family practice certification. They just suggest at least 2 years. It just makes things a little bit easier to find, to come across, things a little bit easier to remember. And this is also one of those examinations where you don't get the apprentice after your certification, after your designation, after you pass. You're just a CFPC, so there's no A to be on there for 2 years. So it's a little bit different, but that's where they're suggesting you also have at least 2 years work to have that familiarity with what you're doing. But yeah, both my friends who took it, they did kind of struggle a little bit taking it, and they've been in the field for a while. But I think what really gets them is that E&M. So if you have some strengths with E&M, great. If you're not as strong in E&M and you still want to take this, brush up on some of those E&M videos, tutorials, review the study guides, review your information, and try and or take the practice exams as well and try and brush up on the E&M.
Good stuff. I'm trying to think if I know anybody off the top of my head that has actually taken that exam, and I can't think of anybody. I know some people that are actively, family practitioner coders, but that's an exciting one. So guess what time it is? Can you believe that we've had the BAT system for 20 years already? Yes,
Can't believe it.
It was 1999 when Laureen officially launched that. It had a kind of a different name back then, and I'm going to mention it here on one of the answer sheets that we're doing. So to celebrate that 20 years, of course, we're going to have a sale. And for you guys, it's really important that you know that it's going to expire, and that's tomorrow at midnight. So 7/19 tomorrow at midnight. You guys are, here with us, joining us, taking time out of your busy schedule. And so you're hearing about the sale first. You can get 25% off courses and Blitz. If you want more information about the sale, just go to CCO.US/BAT-20-year-sale. So jot that down and make sure that you jump out there to the CCO.US website. You can do it before the webinars if you've got an external monitor, right? Or you got another device, you can go do it right now because it's an excellent sell. Anything you wanted to say, Boyd, about that?
Well, Aaron says that the BAT technique helps me so much with my studies. Thanks, CCO. Thank you, Aaron, for that shout out. That's awesome.
We used to call it the bubble and highlight technique, and then we got to looking about we joked about it being in a bat cave, and the next thing you know, it became the BAT system in the bat cave on CCO. So it's been a lot of fun but yeah, that's a long time, and
It's
works.
always evolving. There's changed over the years, and
Yes,
I think
better.
exactly.
Yeah. So not only have you learned with the BAT system from us, but we've learned what you guys desire to make it better. So that's kind of a cool thing too. I get to go next. Well,
Yay.
we're going to talk about, because this is a subject I really like, but I wonder how many of you guys get really tired of me saying that constantly. Every time one pops, like, oh, I love this subject. And this one I've talked about a lot. Myocardial infarctions, a STEMI versus a non-STEMI coding. Again, we've done a lot of education on this. You can go out to our YouTube channel, Medical Coding Cert, and see those. The question, though, was a little bit different, and that's why I grabbed it. It said, easiest way to understand coding myocardial infarction and STEMI and non-STEMI codes. You know, what are they? And so, again, let me just pull this slide answer sheet over. I got to thinking, it's like, you know what, I've taken time to explain what's a STEMI, what's a non-STEMI, et cetera, you know. However, there's this was a little bit different question, you know, what is the easiest way to understand all of this? And I thought, oh, I can do that. I can tell you. So these are the facts. This is what you need to know. First of all, you need to know what a myocardial infarction is. It's a blockage. Right? It's not heart failure. Can you have heart failure? Yes, from an MI. It's like, you know what, I've taken time to explain what's a STEMI, what's a non-STEMI, etc. All you need to know is that a STEMI and a non-STEMI, this was a little bit different question, you know, blockage, what that's being the easiest way to understand the vessel. So with a STEMI, it's 100% blocked. Nothing's getting through. No oxygen, no air, nada. All right. But with a non-STEMI, that means that it's really narrowed. There's blockage, but it's not completely blocked. And the beauty of this is that when they run an EKG strip, they can tell whether it's a STEMI or a non-STEMI, right? Because the waves tell them. Now, again, we've done videos on this before and lots of training. Go to the YouTube channel, and I've got EKG strips where I explained what each of the little humps and loops and all that is. There's no loops in an EKG, but you know, I'm saying I've explained that. So this person wants to know, what's the easiest way to remember all of that? So the first thing is that an MI is a blockage, a STEMI, complete blockage. A non-STEMI is, it's just narrowed, right? So we're still going to have the same signs and symptoms because we have blockage. And you even talked about that. You know, what are the signs and symptoms? Something that you need to be aware of when you're looking at the documentation, and also for testing purposes, but mostly for real world, okay? Remember that if you have a STEMI, a person has a STEMI, and they don't write out what a STEMI and non-STEMI stands for, we've done all that, so I'm just saying a STEMI, then it has to be treated immediately. Why? Because it's a complete blockage. I mean, there is no light, no light in that hole. You cannot see anything getting through. And that means they're going to take them out right away, do an angioplasty, put a cath in, do something immediately. Now, it's kind of protocol that is done right away. It's an emergency situation. With a non-STEMI, sometimes the best thing to do is give them medication, do that, and then see if they can get by with that before, or wait a little while and then do the angioplasty and so on and so forth, depending on how much blockage you have. And of course, there's protocols. So this particular doctor, Dr. Patel, stated that a non-STEMI also often undergoes that cardiac cath, but it doesn't have to be done immediately, right? So when you have a patient that comes in the ER and they're a non-STEMI, then you're probably not going to be coding or looking for that cath documentation. You could, but it really depends on how much, and there's protocols surrounding that. So again, let's go back. What's the easiest way to remember this for the coding? Got it set up. Now, my brain thinks in colors, and I didn't colorize this because I didn't want to overwhelm you, but you guys can get this information too. And again, if you're in our club, you will be able to access and print this off. But first thing you need to remember, the launching point. What's the first code for MIs? That's going to be I21. An acute MI is always going to start with an I21. I21 is a heart attack. Now, because we have the ability to see where that heart attack is going or is happening, then we're able to get to a higher specificity. And as soon as they have that EKG, they can kind of already tell, right? They are able to know if it's the anterior wall, inferior wall, if it's other sites, meaning we got multiple stuff going on, or if it's unspecified. Now, if it's unspecified and it's a STEMI, complete blockage, unspecified means they can't tell from the EKG, the person's had a complete blockage, a heart attack, and we need to get in there and do some visualization to be able to get more information. But all you have to remember is that an acute MI is I21. If it's a STEMI, it's going to be a 0.0, 0.1, 0.2, or 0.3. Very simple. Now, for a non-STEMI, there's one code, I21.4. Whatever you have to do to remember that 0.4 is a non-STEMI, so be it. Maybe just remember a non-STEMI is 4, there's 4 chambers of the heart. I don't know. Now, if it is an acute myocardial infarction, unspecified, we don't know if it's a STEMI or a non-STEMI, but it's acute, then we're going to use the 0.9. And 0.9 is usually a catch-all, unspecified anyway. Not always, but with ICD-10, it's usually. So that's easy to remember. If it is anything else, it's going to be an I21.A. So what do we know right now? That if a person is having an acute MI, it's going to be I21. That if it's a STEMI, you have 4 choices. If it's a non-STEMI, you have 1 choice, all right? A STEMI is a complete blockage. A non-STEMI is, there's still some getting through there, but it's occluded. And then you have an unspecified and an other. Now, the guidelines for testing purposes and just for general coding, you need to know that a STEMI always trumps. Now, if you guys play cards, do you remember, I was like, well, or poker, I don't know what you played, but we used to play rook and some other things, and we would say, okay, trump is a 2, Well, STEMI's trump. That means a complete occlusion is always going to be what you go with. Okay. Just like other default codes and stuff like that we've dealt with in the guidelines, just remember that once you've got a STEMI, it's always a STEMI. So the guidelines tell us if we have a non-STEMI heart attack and it develops into a STEMI, you code the STEMI. If we have a STEMI and it goes into a non-STEMI, so in other words, can we have a complete blockage and then we have not so much of a blockage? Yeah, you could have that because different things can happen with the plaque or whatever it's occluding. It could be a thrombosis, we don't know. So you could have a STEMI that goes to a non-STEMI. Then what are you going to code? Well, you don't code the non-STEMI. This is wrong. Hold on. You don't code that. You code it as a STEMI. I told you wrong. There you go. You code it as a STEMI because the STEMI trumps. Okay. So the only time you code a non-STEMI is when it's a non-STEMI. If it's a non-STEMI and it turns into a STEMI, complete blockage, you code STEMI. If it's a STEMI and then it goes to a non-STEMI, and it can happen, you still code a STEMI because it's a complete blockage at one point, right? So that is something that you could be tested on. Now, the other guidelines and rules that you need to know about STEMIs and non-STEMIs and heart attacks is that you can have a subsequent heart attack. It's very common, in fact, that if you have a heart attack, that in the next few weeks, you're likely to have another one. It's so common. They've got a guideline that writes that's called a subsequent MI. And if you this is not an acute MI, this is a subsequent. So it's now I22. And think of the I21 is you have your first heart attack. I22 is you have your second heart attack right afterwards, subsequent. And there is same rules and stuff like that apply, but this is what it includes. And this is in your manual right next to the I22 codes. It says it includes an acute MI occurring within 4 weeks, that's 28 days, of a previous acute MI. That's called a subsequent. If it's more than 4 weeks, then the first heart attack's an old MI, and this one is a new MI. Now, so for some of us have been coding for a long time, it used to be more than 4 weeks. I think it was 8 weeks, but now it's 4 weeks because it is so common to have happen. One more thing you need to remember to make this easy is that we've used I21, that's the first heart attack, and acute MI. I22 is a subsequent, the second heart attack within the 28 days. I23, when a person has an MI, they could have complications. Now, the complications are pretty defined. So all you have to do is just little light reading and go to your tabular and look at I23, and then you'll see 0.0 through 0.8, and it just lists those complications. If you're not aware of those complications, then go do some studying, go look up the verbiage and everything. But there's just, like I said, a few things that could happen that would be a complication, which makes it a different code. And that is it. This is fun stuff. I do urge you, though, to go to Medical Coding Cert and just type in either MI in the little looking glass or STEMI or non-STEMI, and you'll get a bunch of videos pop up of the training that we've done. Good stuff. And if you're in the club, you're going to get even more training that we've done. Good stuff, I know. Oh, we're ready for another poll. Which area do you feel you need more education in? I can launch that. And here we go. So you have the choice of billing in CPT and ICD, specialty credentials, and then let us know in the chat which one, and other, which might be something else specific, not a credential or anything. And I know that when Jennifer was talking at the very first of her other answer sheet, she made a comment, and I thought to myself, yeah, global days and things. Those are stuff that are on compliance tests. And she said also practice management. You know, you have to be aware of not only global days, but that behind the scenes stuff. And it might be something that you want to get more education on. We do have a compliance course, and I'm telling you, everybody should take it, whether you go sit for that exam or not. It is a good one that will help you test other credentials. So everybody's a little bit slower right now, and I know it's because I just gave you such amazing knowledge that you're slowed down because you're processing, right? You're not picking your choices that fast. Is that why? Sounds good. Either that or you've already fallen asleep. No, that couldn't have happened. Okay, so we are at 68%. I'm going to count you down, and we should be at 75%. So don't forget, let us know in the chat also if it's a specialty credential that you're interested in. And now, are you ready? 5, 4, 3, 2, 1. I love doing that. And I'm closing.
Well, that's a tough question too. So if they feel they don't need more education, if they feel pretty confident in what they're doing, so that's
No. Everybody needs more education.
Oh, I love more education. Don't get me wrong. No.
I was thinking yesterday.
I'm still going to school.
Yeah, I was dry. Yeah, we both are still in school. I was driving back from seeing my grandbabies, and I was listening to an audio book on something that is completely bizarre, but it's educational on leadership and stuff like that. And I was thinking, you know what, I love this because I'm learning something, and it was fun. It was, you know, wasn't dull, or it was exciting. So, and I thought to myself as I was drawing, I love learning. So we have 24% of people say they want more billing, which is excellent. I encourage everybody to get as much billing knowledge as you possibly can. Jennifer, again, is our resident billing expert. If I ever have a question about billing, I'm sending her chat notes, or if people ask billing questions, I'm always saying, hey, heads up, there's one for you, Jennifer. And that is because I'm not particularly fond of billing, which you may already know that. I've said that before, but she likes it and she's good at it. 32% want more CPT. And you know what? Most of the credentials are pretty heavily laden with CPT. So that makes sense to me, you know. But ICD, my favorite thing in the whole wide world, as far as medical coding is concerned, 29% of you guys want more information on that. And, you know, if you're thinking of a new career or just getting into coding, risk adjustment is ICD, inpatient is ICD, but again, the pendulum swinging to where ICD is starting to bear more weight. It's not just given medical decision making and why we do the procedures, but it's carrying more weight as to for billing with risk adjustment. Specialty, we only have 10% and 6% other. Anything in there that came up in the chat?
We had the CDEO,
Ooh, yeah, that's a good one.
COC, CPMA, Whitney's in wound care.
Whitney is one of the people we tend to do a shout out to all the time because she's on all of the webinars. We appreciate her.
Just kind of overall knowledge because they're very new in the field. So they're worried about things that are outside of what they're already doing. So it can be a little intimidating, yes. But
the club is a good
yeah.
place to bounce those ideas and questions because it's a safe place. We've all been there. So, okay, I'm going to move my little hidden poll thing here. What do we have next? Ooh, we have some reviews. You know what? Boyd is excellent about pulling these in for us and keeping them up to date. You notice these are just within a few days and this last week. It says that Deborah on July 13th let us know, thanks to CCO, I passed the CRC on my first try. I love the CRC and I really love having that one. I now have my CPC and CRC. The course was thorough and I would not, or I could not have passed without this training. Thanks again, Deborah. Yeah, it's a fun course to go through. Of course, it's ICD too. Debbie Seaborn, which we mentioned her name a little bit. Thanks to you, CCO certification number 3. Doesn't that make you feel good? Debbie got 3. She has 3 certifications.
Tammy.
What did I? Oh, I'm so sorry.
Put your
Deborah.
glasses on.
Deborah. You know what? They're in my bedroom, but you know what? I've been struggling, so has nothing to do with turning 51 last week, guys.
Nope, nothing. No.
She's using her small screen. Her big screen's over to the side. Yeah, that's it.
It's actually that you're right. I started saying, no, that's not it. Yeah, you're right. You're right. Oh, right. Okay, so we're ready for Jennifer's. Let me get my camera off here. I'll bring this one over for you.
So I had a question that I picked for NICU coding, and I don't do this very much, so I thought it'd be interesting to learn something. So I want to ask a question on how to code for a neonate that's been in NICU for a while. So the baby gained weight over 5,000 grams. They still require intensive care. So which code should they use? A 99233, which is a hospital visit, 99480 intensive care visit, or 99499, which is an unlisted. Most insurance companies don't pay for a 99499. So I had to do a little bit of research on this and a little bit of education. So most of the information that I'm going to provide actually comes out of CPT, because that's where all of our rules are going to come from. So when we think about the NICU, that's a neonatal intensive care unit, in case you've heard the word but wasn't sure what it stood for. That's a designated area in a facility for newborn babies who require a specialized care. So it's not always newborn, but can be newborn. So this area serves for premature babies, as well as those who have some kind of medical condition like a birth defect or infections. Typically, when the facility's billing, they're billing one of 4 levels of a revenue code for that service. But those CPT codes, those are for a provider. So we're looking on the provider side. So when they're doing some kind of medical visit, checkup, services for this baby for the day staying in NICU, the other term we use is critical care. And if any of you remember from CPC, critical care has specific guidelines that go along to meet the standards of critical care. So you have to be critically ill. So one or more systems have to be non-functioning, dysfunctional, in jeopardy, whatever kind of terms you want to relate to. So critical care codes, those can go by age. So we're looking at this initial inpatient neonatal critical care per day, 28 days old or younger. So this is a baby born within the first 4 weeks. So of course we have initial and a subsequent. And then we go to initial and subsequent. They determine them to be pediatric critical care when they're 29 days through 2 years or 24 months. Then it also stems from 2 years to 5 years and 6 years and older. But this question is dealing with baby. So they didn't give us an age range here, of course, to know if they're within the first 4 weeks or outside of 4 weeks. So according to CPT, when a critically ill neonate or pediatric patient improves and they're transferred to a lower level of care to another individual, another provider within that same facility, then you're not going to bill for that critical care service that day. Now they're going to go with subsequent hospital care or a time-based critical care service, dependent upon the condition. So then the receiving provider individual is going to report their code dependent upon the condition of the child. So our question indicated the baby gained over 5,000 grams, but still requires intensive care. So that they're not critical care. They're still requiring intensive care. So there's a little bit distinction there. There is a difference. So CPT has a code, excuse me, 99477 represents your initial day of inpatient care for a child who's not critically ill, but requires intensive observation, frequent interventions, or other kinds of intensive care services. So there is another code to describe those intensive care. These codes are based upon birth weight. So we have a low birth weight, which is between 1,500 and 2,500 grams, a very low birth weight, less than 1,500 grams, or normal. So they're between 2,501 and 5,000 grams. But they don't meet that definition of critically ill, but they need to continue to have those intensive care services, the frequent interventions, and other intensive care services. There are other codes listed in CPT when that neonate or that infant improves, then they no longer require intensive care services and they're transferred to a lower level, then you're going to do your hospital visit or subsequent newborn visits. So for a subsequent care of a sick neonate, younger than 28 days, but more than 50,000, that's a heavy kid, 5,000 grams, but they don't require intensive care services, you're going to use a hospital code. And our 99480 is another code that was suggested in there. That's subsequent intensive care per day for the evaluation and management of a recovering infant with weight 2501 to 5,000 grams. So kind of looking over the CPT codes, there's really nothing fitting our definition because the question asked a baby over 5,000 grams requiring intensive care. So there is not a specific code for that service. They're over the weight that's required in our weight codes for intensive care, but they're not, they still need intensive care, so they don't meet any of those requirements. So the codes for the services, so could we have a documentation for critical care? Is there anything in the documentation that's suggesting critical care, or is it just strictly intensive care? So we need to review that documentation again, and we could possibly bill one of those other codes. But if the codes, they say not requiring critical care, then you're limited down to your hospital visit codes, your subsequent hospital visit codes, which this person requires intensive care. So you can see where it's getting really difficult. So pretty much your documentation is going to have to go with 99499. It's probably the best option. I understand it's not accepted by most insurance carriers, but I'll let you know something from the billing side. It's not accepted and paid upfront. So this is a code. Unlisted codes require documentation. They require a letter comparing them to another code. So it takes some work to get an unlisted code paid. And the majority of the time they can be paid unless that insurance carrier has a specific guideline stating they do not pay them. So if in that case, then you'd have to go with your hospital visit code. But typically most insurance carriers will pay an unlisted code. It just requires work. It requires an appeal. It requires information to send it in. So probably in this case, not knowing exactly how old the baby is, only going by weight and not knowing the diagnosis or the problems that are associated with it. Is it really critical care? Are they down one level? They're still in NICU, but they just need intensive care. Do they meet that critical care requirement or not? So you're going to send a letter after your surgery, after your procedure's been denied, indicating that this is equivalent to that 99480, except our baby weighs a little bit too much. So it does take some work, but that's probably the best code to bill for this type of service, not knowing the entire story, but based on the information we have.
That's really good. And that makes me think that situations like this truly shows how valuable having a coder that has the experience or knows or is can help with those letters, right? It's like you don't just give up. No, there's because this has got to happen a lot. I can think of all kinds of critical care NIC unit situations where the baby's overweight, or not overweight, but doesn't meet the criteria, but they have respiratory failure or whatever, and that's critical, not just intensive. So, right, good stuff. And we're moving on. I feel a poll coming on. What do you think? Nope, not a poll. I was sure I was going to get to do the countdown again. Well, just so you know that if you join the CCO Club, and here's the way to do that, CCO US Forward Flash Club, then you're going to get a heads up whenever we do a live webinar. And we do, at least 4 a week, usually. Not always, but sometimes more. And also, this allows you to watch recordings, and that's a little perk that some of you may not be aware of. Sometimes we'll live stream on YouTube and Facebook, but we bring them down that day or that next day, 24 hours. It's just to kind of give you a hint of our teaching style. So if you want to be on our live event for the ICD-10 updates webinar. It's that time of year. It's going to be Thursday, July 25th. We're going to do it from 11 a.m. to 2 p.m. Eastern. And this is a great link for you to be able to have access to that. It's the cco.pe/2020 ICD 10CM. And I'm going to be working on that, and it's going to be a lot of fun. I can't wait to have you guys join me for that. Now we get to talk about SloMo Surgery. Oh, I bet you didn't even know what that was, because when we have students that talk about Mohs surgery, they're usually a little intimidated. That's the students. And then even after you've become a coder and you come across this, it can be
Isn't that a
intimidating at
cowboy
first.
character like SloMo?
SloMo.
SloMo came out of the saloon after, you know.
You're right. I was thinking slow motion, like slow motion. Da, 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 you know. Okay, so the question that came in was, I've been seeing provider bill for SloMos procedures which do not meet the criteria of a true Mohs surgery. These involve the same anatomical site, the provider billing Mohs as the first stage of an excision and then completing the surgery with an excision billing with an excision code as well as a repair code. Is this allowed under CPT guidelines? So my question is, what is SloMos? I thought a provider had to either perform an excision or use Mohs surgery. Well, let me just find this and pull this over. This was really exciting to do some of the research, and I have to say I found a couple articles that were brilliant. So again, if you're in the club, I've put a footnote in there on where to access those articles, and I urge you to go look at them. One of the articles wouldn't allow me to like grab a statement and copy and paste it, and so I had to type out the information, but it was, I couldn't have said it any better, a couple of these paragraphs. So that's what I did. There was actually a dermatologist, Dr. Ellen Marmer, I think that's how you say her name, and she's out of Mount Sinai in New York. And I loved what she said. She said, SloMos has gained universal acceptance. Now, just a heads up, this article that she wrote was 2011, so that I found. But in my research, nothing's changed. I couldn't find anything more current. So what she went on to say is that especially this acceptance covers definitive surgical technique for the removal of lentigo maligna melanoma, which is a specific type of skin cancer, while simultaneously sparing normal tissue. And that's what Mohs surgery is all about, quite honestly, is being able to remove the melanoma without taking, you know, if the melanoma is the size of your fingernail, they end up having in the past taking out, you know, that much and deep to make sure they got all the margins. Melanoma is extremely aggressive cancer. So then she went on to say, SloMos is a modified form of Mohs micrographic surgery. So you have to understand what Mohs is first, and I'm going to give you a little heads up on that as a refresher. The surgery compares with conventional Mohs. It is staged, margin-controlled excisions, just like Mohs, but in SloMos, the difference is they do a rush permanent section that's sent off to the pathologist rather than frozen sections that are integral to conventional Mohs. Well, I thought, okay, that's really, I understand what they're saying, but then I got to thinking, you know what, maybe other people would not realize exactly what she was saying. And so I pulled out some more information from her article where she said SloMo can take place over a period of days. And she goes on to say, basically, you do your Woodlamps, which is the special thing they do to define the diameter of the lesion. And then you measure out your margins, how far out you're going to go and everything. And then you excise the tumor, you take it out, and you pack the area, etc. And you send that person home. And then you send off the pathology and you don't do reconstruction, especially we're thinking like if they do it on the face, until we have confirmation from the pathologist that the margins are clear. So now, what I want to tell you about SloMos, and this is the kicker, and I put it down here a little bit later, is that with Mohs surgery, the key is that they take the cells, okay, they kind of slice them off in a layer, and then they segment those layers, and then they go over to the microscope and they look at that, and they say, okay, we got quadrants, we got 4 quadrants, you know, just like the abdomen, upper right quadrant, upper left quadrant, lower right quadrant, lower left quadrant, and you wait and you see if there's still cancer cells, then you take another layer and then you quadrant that. All right. Now, we've done a lot of education on Mohs procedures. So again, go out to Medical Coding Cert on YouTube, and you can see plenty of explanations about Mohs. I like to go watch Dr. Sandra Lee. She has, I think, 2 Mohs surgeries where she shows you how she segments them and color dyes them in different colors, and then explains the cells that she's showing, which is excellent, I think. You may know her as Dr. Pimple Popper. Now, this example, though, is SloMos is like that, except the provider that's doing the surgery isn't actually the one that's looking under the microscope. The provider sends it off to the pathologist. Okay, that means it's not Mohs surgery, and I'm going to explain why. But first, let's talk about why SloMo works so well. It is another excellent article that I found. They stated it was a very useful technique for histological subtle neoplasms. They're difficult to recognize on a frozen section. Right. So the examples they give, and the reason why I wanted to give you this is that if you see these diagnoses and they're probably going to do Mohs procedure, right? Or maybe they think you're going to say, oh, well, we think we have a sebaceous carcinoma or Paget's disease, you know, then expect Mohs surgery is going to happen, or slow Mohs surgery. So those were that maligna sebaceous carcinoma with intraepidermal pagetoid spread, extramammary Paget disease, dermatofibrosarcoma, protuberans. No, there's a B in there, protuberans. I'm just having fun saying this stuff. Acroleginous melanoma in situ. I think you guys should all learn how to say that. Anyway, it says with the SloMo, it represents the staged excisions, because that's what we're doing, you know, with Mohs, is we're doing staged. We look at it immediately and then go back and take more. But in contrast with Mohs surgery, here's the kicker. The margins are processed as a rush permanent section. So in other words, they're going to send it off. They're not going to look at it right there. And then it goes, we've successfully employed this technique for several years. Yes, this was another one that was, I think, 2011 also. And they've been doing it for several years, and now we're in 2019. We've successfully done this for several years, but it's a complex procedure. And it says it depends on collaboration, precise communication between the surgeon and the pathologist. Now, this is what you need to know. The best results are if you follow this technique. So our person that asked this question, they need to know that to be able to do SloMos, you have to have some things in place. First, you're going to let the laboratory know that you're going to do the SloMo procedure, because you're going to be sending it off for them. And that you need to evaluate the original neoplasm, right? It's not going to be frozen. In other words, it's going to be done right away. They put it in paraffin. The original biopsy was not reviewed by the provider. Now, that means it's not Mohs surgery, because the surgeon evaluates in Mohs surgery immediately. It still can be sent off, but they're giving their opinion right away. So it's very important that when they send that off and it's SloMo, they tell them, you know, we didn't evaluate this biopsy. And then this can be achieved by submitting the debulking specimen, blah, blah, blah. All right. And that it goes on to say well, I wrote this part. In Mohs, okay, the provider doing the procedure is the pathologist. They're putting the hat on as a pathologist. They're looking the cells and they're saying, nope, we need to go deeper. Now we need to go on the left upper quadrant. There's still cells there. And then we're going to go deeper and just do that area. And so we don't end up with a hole like this. We end up with just this much, right? As we're able to pinpoint it. That's why it's brilliant. But the key here is if a pathologist is doing the reading and not the surgeon, it's not Mohs. So this is your codes, your main codes. There's other codes for Mohs surgery, but they're add-on codes. So you got two main codes, 17311, and that's Mohs surgery on the head, neck, hands, feet, and genitalia. Right, then you have 17313, and it's the exact same thing, Mohs surgery, but it's going to be on the trunk, arm, or legs. All right, so it's either or. Now, if you're going to do in other words, the extremities or the trunk, then it's 17313. If it's anywhere else, it's 17311, and then you have add-on codes for how extensive you go after the 5 tissue blocks, et cetera, et cetera. That's Mohs surgery. That means that the surgeon that's taking the tissue is looking at it and rendering an opinion, like a pathologist, right away, right? But that is not SloMo. Now, here's the things. All stages done in one day, if that's done. If you report a single excision and use a final, you're going to report as a single excision and use a final diameter. And then you're going to, if you do a tissue transfer, which is often done, especially on the face and stuff, the same day, then excision is included in the adjacent tissue transfer code. So this article by Dr. Dirk M. Elston, brilliant. It was called Mohs and SloMos, and I linked it down here so that you guys can find that. He stated, although you and I know what we mean by SloMos, and I will use that term in the article going forward, because I suggest that you avoid the term in the medical record. He's talking to the providers, as it confuses the auditors. Instead, refer to the procedure as an excision with margin control. So the person who asked this question can go back to their provider and say, you know what, just don't use the term SloMo. We know it's SloMo, but it confuses me because it's not really Mohs surgery, right? And that means it's going to confuse auditors because they're looking for SloMo. So if it's SloMo more than 1 day to complete, the final excise diameter is reported on the first day. You're going to do additional margins on the second day, and you're going to use modifier 58. Very important because it's a staged procedure. Now, this is something you need to know, and this is billing. This is very important. Mohs surgery, when you do that, it has no global days. However, SloMos, which is really an excision and it's a malignant lesion, has 10 days in their global period. Now, if you do an adjacent tissue transfer with the SloMo or the excision, you get a 90-day global period. And that includes the excision of the malignancy, and it's performed on the same date of service. Now, let's say you do closure, a complex closure, which is going to not be a tissue transfer, right? Then it has to be the same date of service. You have, you're subject to multiple surgery reduction, because when you do that on 1 day, you're going to have a reduction in payment, right? And Mohs is not 51 exempt. So you need to pay very close attention to the date of service reduction rule, right? Again, These are just highlights, but this stuff is stuff you can take back to the provider and say, hey, look, this is why we need to get away. Is it Mohs surgery or is it not Mohs surgery? And it's really an excision with a complex closure or an adjacent tissue transfer. Then the article went on to tell us, and I'm sorry that physician is spelled wrong here. Okay, so when is it not Mohs per the AADA? And this is a brilliant way for you to be able to get, these are the people, the experts that advise everybody, CPT and AMA and all of them, on protocols and stuff. It says, when all your specimens are removed during the course of the procedure and sent to a pathologist for interpretation of paraffin sections, because they don't freeze it, then Mohs is no longer being performed because the surgeon is not the one looking. He's not the pathologist at that point. Let's see. Instead, the physician removing the tissue should characterize that process as an excision and document it as such. Or when a separate physician, such as a pathologist, because they're a physician also, reads all the slides made from tissue removed by the physician during a particular stage, this will constitute delegation of responsibility. And as such, make this stage incompatible with Mohs surgery. This differs from the slides for margins assessments, but that obtains additional second opinion pathology consultation on a portion of these slides. And again, I footnoted where you can go read that entire article because it was so good. If I could have just brought it up and showed it to you, I would have, it would have had everything you need to know. So routine review of histological features of tumors being treated with Mohs by pathologists is not compatible with Mohs surgery. Now, in some rare number of cases, though, you could have a pathological consult that might be needed. If you want more information about those paraffin sections, then there is a website that you can go to, the aad.org/forms/policies/px.aspx, and that will highlight where this provider got the information about sending that stuff off in paraffin to sending it off for the pathologist. So I know that was a lot of information. It was a lot of fun to research, guys. Really, really fun. I learned a lot. All right, moving right along.
Well, we did have somebody ask a question, and because you were very in depth, and for somebody who's just starting out and learning, yeah, that's not really going to be on the exams.
No.
So this is more for people specifically in dermatology and specifically dealing with these types of things. So don't be afraid. Nothing.
Don't let that freak out. I should have said that ahead of time. So, and that's another thing that's really important to mention, that when we do these webinars, these are topics that you guys bring us, and sometimes they're light, you know, and new coder related and stuff, like one of the ones that, you know, about taking the exam or taking that particular family practice exam, or just something simple about modifiers that, you know, we think, well, we know the answer to that, but this person's struggling. How can I unpack that and make it easier for you to understand? And then other times we get these ones that are like, oh, wow, I really got to go in and look and get some second opinions and help. This is, you know, you're only as smart as the people you surround yourself with. But that was very in-depth, and I enjoyed doing the research on that. It was fun. Oh, we get another poll. This poll: how many CCO webinars have you attended? And thank you for also asking if this is something that would be on the exam. Feel free to do that. If you're in the CCO club, you can ask questions like that all day long, you know, and say, hey, am I going to get tested on XYZ? And we'll say yes or no. Ooh, you guys are awake now. So is this your first time? Yay! And hopefully a question, if you're new to coding, that didn't freak you out. Back for more. Are you a repeat offender? Are you liking it here at CCO, or are you a CCO frequent flyer? We have quite a few frequent.
We do have some of those, yep.
And a lot of them are on the CCO club. And like you said, you've seen us dropping some names already, like Whitney, and you know, we see them and we hear from them a lot, and very interactive and great questions, and we like that. Speaking of that, while we're real quick, I was just at the Dallas Central local chapter and lectured on ICD-10 PCS day before yesterday. It was so much fun. So if any of you guys are watching, I told them I would give them a shout out. It was wonderful to see them. That was fun, and I got to see my grandbabies at the same time. Okay, we are over 70%. So 5, 4, 3, 2, 1, and close the poll and share. Ooh, do you see it?
We got lots of
Wow.
new timers today.
Hey,
Yeah.
Nice.
welcome.
But look how many frequent flyers. Wow. Yeah.
So for those only listening, first time was 28%, back for more was 8%. Repeat offenders, which is 2 to 5, is 23%. Liking it here at CCO, which is 5 to 10 webinar attendees, attendances, I should say, 14%. And 10 plus webinars, which we like to call CCO frequent flyers, 26%. So awesome.
Thanks, guys. Thanks for trusting us with helping you become more educated or increasing your knowledge base. Ooh, we got another good one. Okay, let me move this over for you.
So we had a question come in, and it's more on our business side here of medical records. So are electronic records being saved the same as a hard copy, or, you know, when we used to put it all on a piece of paper? So for legal purposes. And then how long does the current law require you to keep those records? So this is pretty interesting. So one thing we need to keep in mind about medical records, it doesn't matter how they are, if they're on paper or if they're electronic, or if they used to be paper and you somehow converted them all to electronic, there's a purpose for these medical records. So we need to keep in mind that the first thing about medical records when you're dealing with the law is your state law. All the states are different, of course. Every state is different. I've found some very interesting things about some of the states. Some say 30 years, some say 15, some say 10, some say 6. So it really just depends upon your state, as well as the licensing agencies. If your facility belongs to the Joint Commission, they have a certain amount of time. Insurance carriers require a certain amount of time. So we kind of have to take this all into account when dealing with looking at these medical records. So how long do we have to keep them for? Well, of course, HIPAA. We all know HIPAA. We all know that all the rules, the Administrative Simplification Act of HIPAA states that we need to be kept for 6 years from the date of creation or the last date of effect, the last date it was used. So it depends. You know, some people need to sometimes query or run a system diagnostic report, data report of when was the last time people were seen before they can get rid of medical records. Now, a lot of times when they give some of this information, there's nothing specifically about electronic medical records because they're electronic. You're keeping them, and hopefully you're keeping them off in another data system somewhere than what's actually physically in your office. Not could be the cloud, but we've seen problems with that. But some other off-site data facility as well, keeping backup. That's very important. Medicare Advantage plans, your plans that are being paid through Medicare system, your Part C Medicare plans, could be Humana, Aetna Medicare. Everybody's got a Medicare plan out there. They require 10 years, whereas Medicare requires 5, both for the facility and an office. If you're a critical access hospital, they require 6 years. And that's actually from the date of kind of, they call it a post date, like your payment date. It's kind of where they use their date, 5 years. But remember, False Claims Act, they can come back and come up to 7 years, possibly up to 10 years later with charges against the False Claims Act. So your fraud, your abuse, anything going against false claims, they might go up to 10 years. So you want to make sure you have those medical records on there to prove services were actually provided and medically necessary. What if you're dealing with a minor? I'm in orthopedics. We have people come in when they're 2 years old because they fell off their bike or, whatever, fell out of bed and broke their arm. Well, there are two. How long do we keep their medical records for? Typically till the age of majority, which according to your state could be different, but most people use the age of 18. And so now we've kept that record for 16 years, plus we have to keep it the statutory limit as well after they turn 18. So I'd be surprised, really. We get these requests all the time of people going into the military, and they require that medical record to prove that that broken arm they had when they were 3 has been healed. Well, if we don't have that medical record, how can we prove that? It depends on what type of population you have. Actually, if you're a research facility, the FDA requires your research records to be on hand for 30 years. So that's a lot of information to be kept. So usually the law is whatever is longer. If your state requires them for 15 years, then that's the longest you have to keep those records. If it's, remember this, different for minors, different for different things. But if JACO or some other accrediting agency requires them 7 years and your state only requires them for 6, then you go with 7. That website, the link there, is IT company through, it's .gov though, that lists every state and what their requirements are. So it was a good link to have. You can also just kind of Google state requirements specifically for your state if you need. It'd actually be on your on your states.gov website. You kind of have to search for it, but they're all listed there. So in dealing with the first question about the electronic records, we need to remember that electronic medical records, or we abbreviate EMR, is actually different from EHR, but electronic medical records are the digital version of the chart. So it contains your office notes, information about your diagnosis and your treatments that were listed. That's your EMR, your electronic medical record. It's for your medical treatment. EHR are electronic health records, which integrate all the services involved in patient care. So laboratories, specialists, radiology, anything else. These records are intended to follow the patient for life. So EHR, this is their intent. So we may not be there yet, but that's why Medicare came out with all those rules, almost 10 years ago, and paying incentives to start generating your EHR systems, because they want to keep all this information and have it accessible. So these should be kept the same as a hard copy, because it's to support the purpose of the treatment. That is a legally binding liability for your services that were provided. We need to make sure everything's kept and accounted for. When your statute of limitations has expired, whether it's an X-ray film actually on an actual film, paper record, electronic record, it can be destroyed. So your office should have a policy in effect as to how you deal with medical records destruction and archival. And you would also want to get this assistance of a company attorney, your malpractice attorney, somebody to make sure that you are properly disposing of your medical records. There's actually a certain way to do it. Make sure that it's all kept HIPAA. Now, you could use archives, and some hospital systems may use this, because just think of the amount of work that goes into a hospital medical record system or EHR system. Everything being done, every doctor ever seen, every time that patient comes in the ER, anything linked to the hospital. So they might archive the information. They may keep the medical records archived in one server, one system, where the PHI then, all of their demographics, all of the data, all that private health information is kept on another server or record. So it kind of, you think of the amount of data. So the PHI may not take up as much information as all of those medical records. So sometimes it could be done that way. Now, personally, my company's been in business maybe almost 30 years now. We still have every record from the first day that person came in. So we have everything on our electronic medical record system. We used to have them all paper, and they were all converted because they were all digitally typed, digitally transcribed. So it was all converted into our big electronic system now. So do we want to get rid of that stuff? You know, it's just little bits of information. Is it taking up that much space? Another thing to keep in mind is if your provider retires or goes out of business or something like that, there is a proper way to get rid of those records as well, and you need to contact your state attorney's department to figure out what is their method to keep those medical records, because they must be kept. Just because they're retiring or went out of business doesn't mean you throw out everybody's medical record. They must be kept. So the state's attorneys for your state deals with that as well. So in case that you have a practitioner who's retiring, that you need to make sure that they're looking into that properly.
I had a provider who was an allergy specialist, used to write long documents and stuff, and then had myself, my husband, a couple of the children allergy tested, and then he up and went and had a heart attack. And so his records were, you know, put aside. And so like a year or so later, we went to go get our records, and they had an awful time getting them.
Oh, yeah. Yeah.
But it's okay. It's good to know that information. And those are on compliance tests, that stuff that you just talked about. So those are things you need to know for more than just a regular job. They're on compliance questions. Let's see, we got a poll. Are you a member of the CCO Club? Well, I keep talking about it, so I hope you are. Let's see, here we go, launch. This one should go really fast because it's either a yes, no, I decided not to join at this point, or no, I didn't know about it. Is it important? So, ooh, wow, we got a lot of people that are. That's great news. Okay, excellent, excellent. So we are already at 60%. I'm so glad. That means you guys are still active and with us, and this stuff is exciting, I know. So we can do our countdown already. 5, 4, 3, 2, 1, and close. Wow. So I'm looking here, and it says 41% said yes, you're already part of the CCO Club. So the perks are that you're going to get these great recordings and everything that with all those links that we told you about. 33% nope, I decided not to join at this point, and 26% no, I didn't know about it. Is it important? Yeah, it is. So I encourage you guys to go out and look at the FAQs, you know, and it is something that we do have you pay monthly to be a member of that. And it may not be the right timing for you, and it might be something that you want to do later. You could always ask it for a birthday present or a Christmas present. There were some great graphics that I saw the other speaker in Dallas showed us, and I thought, oh, I want those. So I had my iPad and I went and looked while she was talking. $197 for those graphics, but I really wanted them. And I said, I'm going to ask my husband for those. It'd be better than jewelry.
We can tell people how they can go join the club.
Oh, there you go. Yep.
Yeah, it's at cco.us/club. Easy.
Yep. 2%. And these are all the things that you can get, the benefits from the club. Or just ask us about it. We'll tell you more. So taking the CPC exam, this is the last question. And really interesting. I want, Boyd let me know that he pulled out on June 27th and stated, I passed second time around. Woohoo! Very happy and relieved. I used everything that was available through the CCO Club. I'm so glad I found you. Now ready for the next step on this road to the new career. Thank you, CCO, which is so applicable. Thank you, Boyd, for adding that to this question that came in. Said, I have taken the CPC exam twice and failed. I won't fail the next time. I need to know where to start. I think I get confused on how to study for the CPC. Do I start with the BAT technique? I know medical terminology pretty well. I just want to know how to study. I know your BAT program helped me so much with the last exam. However, I just need assistance on how to start. So we, I really liked this question. And I thought, you know what, I'm going to break it down because we talk about a lot, but this was very specific. She goes, I just need to get started. So she already has the BAT technique. She's already taken the exam twice and failed. And let me tell you something, guys, people who tend to take it more than once are either just something that I do where you go and you set for one of the exams and you just wing it. That's not a good thing to do. But you're either just were woefully not prepared, or you overthink things. And the ones that tend to overthink a lot are people that have been doing a little bit of coding or have a medical background. They tend to overthink when it's really a simple question that they want answered. So first of all, it's important that you understand what the BAT technique is all about. We mentioned it, that it's a 20th anniversary. So I wasn't even thinking about that when I picked this question that came in. It used to be bubble, highlight, and annotate technique, but then we realized, hey, that's BAT. So it is proprietary. Laureen came up with this in 1999, and it has evolved through the years, and it's specific to the CPC exam because it helps you bubble, highlight, and annotate your CPT manual. Now, we have ways to make notes in ICD, but ICD is already set up in a kind of a user-friendly way. CPT is not so much. And so Laureen found a way to do that that makes it a lot easier to go through. So when you get the BAT technique, and if you're one of our students, it just comes with the course, but maybe you just want to get a blitz with the BAT technique for the CPC, and there is not, I'm not sure to say a protocol. There's really not a protocol. What you're going to do is first, you're going to end up reading through the guidelines because that's what you're being tested on is the guidelines. And we tell you that we want you to read them 3 times. I tell people read when you first start, read them, just go through them. Now, they're going to be intimidating and you're not going to understand them. But if you know that going in, but you need to peruse and kind of see what I don't know, then you're going to go through and start bubbling and highlighting and making the notes that we suggest to you in your manual. This is something that once you learn the technique, you do it on your own. You personalize it. Just don't go overboard. We have through the years, we've come up with ways to make things pop off the page better, and we've tweaked them through the years, and as codes changed, of course, and made updates and stuff, made it better. But after you go through and you get the technique down and go through your manual, then you go and read the guidelines again, and then they make sense because they are reiterated in the individual sections of the CPT manual. And then the third time you're going to read them is after you've done some practice exams. So number one thing, don't freak out. It's going to be intimidating at first, but the more you handle and get up close and personal with that CPT manual, you will become better at coding. You will be able to flip through pages and get there faster just because you already have a feel for where things are laid out. The other thing I would suggest is look at your testing. When you pass, they don't give you any information. They just say, oh, you got an 84%, you passed, ta-ta, there's your credential. Now, if you don't pass though, they will say that you failed. You click on that and it'll give you a breakdown of the percentages you got in the different areas. Now, Jennifer mentioned earlier that unlike for the family practice, they don't tell you the divisions of that exam, but all the other ones pretty much they do, especially the CPC. So you know that you're going to have 8 to 10 questions on terminology, 8 to 10 questions on uh, uh, the 7000 series in E&M, in medicine, and they even give you topics to look at. So the ones that I find that people struggle with the most are the medicine section. They struggle with E&M, and usually there is a series, meaning that first character like 7000, the 5000s or whatever, that they struggle with, not necessarily the 7000s, but there'll be one in there. It's like, oh man, I really blew the 5000 series. Okay, so knowing that, then go back and find out if there's any guidelines specific to that area that you can reiterate and reread. And that's that third time that you read it. Also, number one reason I think people fail is they overthink it. I see it in our students that ask questions. And I like to explain it this way. When you look at that, what color do you see? Now, most people just say, okay, well, that's brown. But my mother was an artist or is an artist. So I know all types of browns. I may look at that and say, well, it's kind of terracotta, but no, you know what? I think it's burnt umber. No, it's definitely burnt sienna because of the little yellow overtones. Yeah, I'm going to say that's burnt sienna. But that's not what I was asking, right? I'm just saying, what color is this? It's brown. Don't overthink it. And people who have been coders, people who have a medical background, they're coming in with all this background knowledge and it tends to mess them up. So I gave you an example. And I wanted the person that wrote this question to think about this because, again, this is the number one reason why you fail. The question would be a scenario that you might see like this. Mrs. Brown is seen by Dr. Feelgood for a refill of her insulin and directed to use the adjusted sliding scale. Hypertension is under good control with oral medication and refill given. Referral given to Dr. Tarsal, funny, for possible ingrown left great toe. Now, here's your choices because this is multiple choice on the CPC. You have 4 choices, and if you've played with ICD, now this is not CPT, this is ICD, but this is the easiest way for me to give an example because I know ICD so much better. You're looking this and you're overthinking it because you're saying, oh my word, the person's on insulin, they're a type 1 diabetic, so that's E10.9 and they have hypertension. Oh, wait a minute, no, they've got a problem with their foot and that's a skin problem, so it's E10.628, they've got hypertension and long-term insulin use, Z79.4, so okay, B. But you're forgetting that the guidelines, which you're being tested on, tell you that if you're not given the documentation to say if the person is type 1 or type 2 diabetic, you default to type 2. Why? Because like 98% of all diabetics are type 2. So E10, which is type 1 diabetes, is not the right answer because we are not told if they're a type 1 or type 2. So A and B is immediately crossed out. Don't overthink it. Right? Now, that gives you 2 choices. We know the person is a type 2 diabetic because we don't have documentation telling us otherwise. And we know the disease process tells us that you can be a type 1, you have to have insulin, but a type 2 could use insulin. And sliding scales are often used with people that are on insulin. Our patient is hypertension, but some people overthink and say, oh, but it's under good control, so they don't have hypertension. No, they still have hypertension because if they quit taking the medication, they would need, they have hypertension. You don't get rid of hypertension as a general rule. So we need to code for the I-10, which is the first code most people learn. Now, the next thing is insulin use. Yes, the person is on long-term insulin use, so the Z79.4 is a good code to have, but they've got the ingrown toenail problem, right? And so that means they're diabetes, because whenever we got a problem with the diabetes, they told us there's this causal relationship and we assume it now. But the problem is we didn't pay attention to this little word right here, possible. That is not a definitive diagnosis. He thinks this person has an ingrown left great toe that should say nail. Anyway, oops, but they don't. So we can't code that, right? So the right answer is C, E11.9. And this is how you look at that very quickly. And the guidelines that I just told you. We default to type 2 when we don't know the documentation. That one's out. The second one, possible ingrown toenail, out, plus they're a type 1 diabetic. And then here, hypertension is coded even if it's under control. The person, we don't know that they have an ingrown toenail. We think it's possible. So the winner is, we should be able to answer those like that. Now we still have to look those up, but the BAT technique, just leaving you with this, take practice exams. If you've already done the test twice, you just need practice exams, and consider doing practice exams in specifics like a certain area, medicine exams. If you've taken a course, you can go reiterate those chapters. We offer an ICD-10 practice exam free that you could go and do. And the last thing I would say is just relax. Don't overthink it. And that's that. Yay.
It's kind of funny. My daughter is looking at getting into college early, and she had to take either the SAT or the ACT to get in. Well, the SATs are all done for the year, so she found an ACT. So it's like 4 weeks before the ACT test. She's a sophomore. It's a senior test, and she's like, okay. So I got her a book on, ACT from the library, and so it was last weekend. I said, how'd you do? She's like, oh, pretty good. I said, is it they had those 2 answers that sound exactly right? And she goes, yeah, the book says don't go with either of those. They're a trick to have 2. She goes, it's one or the other. So we'll see how she did. So
I want to find out.
that works for the ACT. I'm not going to say that for the CPC.
Yeah. Yeah. There are techniques that for testing, and the BAT technique and our blitzes give you even more information about that. Also go to the YouTube channel and you'll see we talk about this a lot. Hey, if you guys would do a survey for us, we would really appreciate that. Go to cco.pu/QA201907 and let us know how we're doing, how we can improve. Or just kudos, you're so perfect, you could not improve anymore. No, we want to know how we can make it better for you. Our reason for doing this is to get you content and information that you actually need. So it's time to pick a winner. And our winner gets to pick between a Blitz video package. Maybe you want to do the CPC review. You can get a year of the CCO Club Basic or our session. It used to have like all kinds of people's names. Now it's got mine. I'm sure Jennifer would talk to you too if you wanted billing.
We've already pulled that name, and luckily she came back in because she couldn't hear for a little while. She had some computer problems, but Bernice Cohen is our winner today. So hopefully, Bernice, you can hear us now. And you have the choice of a Blitz video package or 1 year of CCO Club Basic, or there was another choice there. There's another choice there.
An hour with me.
Yeah, a little consultation with Alicia or Jennifer or Lorene.
Sorry, I went too fast.
And Lorene does send her regards here tonight. She had another event that she had to be at tonight, so she's with the family as well.
Yeah.
But she's fine.
So if
congratulations,
if you want to, oh yeah, you told them to go to the help desk, right? Help desk at cco.us, Bernice, and let them know that you're the winner. Okay, so the CCO Club has up to 80 CEUs in there. And again, you can go into the club and read the FAQs. They're fun CEUs. Now we're going to answer your chat question. So, we're done, guys. If you don't want to stay with us, you don't have to. But here's some questions that came up, and Jesus was so kind to pull these out and set them up, and Jennifer and I will work on answering them for you.
Also, I want to just point out that you've got a handout that we put up in the webinar, GoToWebinar control panel. You won't be able to get that if you're on YouTube or Facebook, but those of us in the webinar, you can download all the slides here. Unfortunately, the answer sheets don't get included in the handout, but you can always get those inside the CCO Club. Another reason, that's a great reason to join as well. But all the links that we refer to are also at the end of the slide deck here that we'll go over, and that's always helpful if you're looking for something later.
Good deal. All right. So usually Sylvia and Lori are in the background pulling these, but Jesus did it for us. Thank you, Jesus. Actually, Sylvia and Lori are both on vacation. Can you believe that? We actually let people go on vacation.
Full screen, please.
They don't let that in my
Oh.
job. Two people
Okay,
from
go
one
into full
department can't be gone.
That's right.
Yeah.
Oh, right. It's loading. Sorry, guys. I didn't put it in full screen ahead of time. So the first question is, after passing the CPC, how do you keep up with or improve skills? Also, my job is going to train me for home health coding. Good for you. Will this count towards my A removal? Well, yes, it will. No, well, will the training count, or her job?
She's on the job doing it. So
Yes.
the job will,
Okay.
the job will submit a letter. You have
Mhm.
them type up a letter indicating that you've been performing the duties of a CPC for 2 years. Yep.
And we did a CCO live the other day. We talked about this. It's important just to keep it short and simple, sweet, when they send that letter in for you. But yes, it will. And home health there's a big need for coders out there, as APC does and HEMA, neither one have a specialty for home health. And it is very different. It's very, very different. They like to get RNs that can do that are coders, because then they can make them fill out the OASIS. You have to be an RN to fill that out. So that was a really easy question, guys.
Well, but how to keep up with or improve your skills.
Yeah, okay. First half of the question. Well, I can give advice what I would do or what I do, and besides going to meetings and everything, I sign up to be on email lists. So things like Z Health, they're great for cardiology, interventional radiology. That day before yesterday at the Dallas Central, the other person that was lecturing was Kimberly, I think her middle is Joviet Williams. She was excellent, and she talked about lower extremity coding and has a CCC, and gave some great resources. But I think getting on email lists is probably the number one thing I do, because if I'm too busy, I know that I just save those articles and I can go back and look at them later. Those 2 articles that I pulled for that content today for the SloMos, I didn't know much, and I've heard of SloMos, but I had no reason to talk about it or look into it anymore. And then I was like really fascinated about it. So again, just knowledge base increasing. One more thing before I let Jennifer give a turn is I try to pick something every year to increase my knowledge base. So last year I picked interventional radiology because I knew very little about it. And I mean, I know the diagnosis side of it, but I didn't understand the procedural side of it and the coding and the billing. So I worked really hard to bring that up and learn some really fascinating things. So this year I was working on oncology, but I started out really, really good, but then I kind of petered out here at the end. But I've got some good resources saved that I'm going to go back when I have time to do a little light reading. So.
You're so funny when I have time. So, for me, keeping up or improving my skills, again, I'm on the billing side, so I do belong to all of the email services for Blue Cross Blue Shield, United Healthcare, Medicare, Cigna, Aetna, everybody. for my side, our local Novitas is our MAC carrier for Medicare. They do all sorts, every Medicare carrier does, but they also do all sorts of free webinars or free symposiums or something. And it's CEUs that you can use.
Yeah.
So, and they're free. So that's always a good resource to use, just keeping up. I mean, I did go to the Medicare Symposium in Delaware a couple months ago, and
yeah.
I learned a lot, and to now have a contact with, that a carrier was really nice. And also, like Alicia, we are both getting extended education. So I'm going for my master's right now. So, and sitting for 2 AAPC exams and now a HEMA. So, so I mean, I do keep studying. I actually have a person that I consult with who's in mental health, and I have learned so much about mental health. And it was so really funny because I posted a question on my master's discussion board the other day, one of my classes, and the professor came back, "Oh, that's so great that you work in that field. I used to do psychiatric." I'm like, oh my gosh, now I got to send her all these questions. It's like, oh, this isn't regarding class. Hey, can you help me with this? So I just keep meeting more people now. But yeah, always reaching out and finding. Actually, another way I learn a lot is I give presentations at my chapter. So if there's something that you're good at now and you want to become more proficient at, offer to give a presentation at your chapter. And everybody is going to learn something new, and you will learn more in-depth information as well, because you got to put it all like on slides or something and kind of organize it, so you'll start to learn a little bit more about something you already know. So
I thought of another one just when you said that, just networking, because I said earlier, you're only as smart as the people you surround yourself with. And another way to network that some of you may have forgotten, maybe you still do this, but LinkedIn is really good. I would say 99% of all the LinkedIn connections that I have, and I'm at over 15K now, is they are in the medical field, and most of them are coding related. So it's not just about getting jobs, but it's being connected. So I saw one the other day that was she was in oncology and something else that perked my interest, and I was like, oh wow. And I made sure I wrote down her information, and I sent her a message and said, if I have a question on XYZ, can I reach out to you? And she wrote back and said yes. So yeah, excellent. All right, here's the next one. If you're taking your CPC exam, can you print out the guidelines for ICD-10 website and have it bound? You can print out the guidelines for the current year you're in, because actually the book has the previous year. For the most part,
depends on what book you have, but yeah.
And so yeah, because now that, well, a year or so ago, it's like people all of a sudden realized that, but it had been that way forever, and they kind of threw a stink about it. And but yeah, some of them have the guidelines, the current guidelines in them. But yes, you can. But keep in mind, if you bring in paper, you have to leave the paper. You can't remove any paper, whether you wrote on it or not. That's keeping the quality of the testing standard high. And so, but you can. If you are in doubt, you need to get a hold of your proctor before and ask them, because just not all proctors are made alike. So if they see you walk in with paper and they say, oh, you can't have paper, it says right here, no paper. Well, it also says that you can have the guidelines, and there's an 800 emergency number you can call on the day of testing. But it's always good to reach out to a proctor and say, I'm going to be bringing a copy of my guidelines, or the guidelines. I just wanted to let you know in advance. And then if they doubt that, then they can call ahead of time.
And they have to be the official guidelines.
Right.
So when you print the paper, it's going to, anything from any website, of course, comes from written on the bottom where it's from. It has to be the official guidelines. And I wasn't sure about the bound part, if you could have it bound.
I don't think I would try to do that.
I mean, it's just
staple
paper you're printing, just staple it and bring it, would be my opinion. I know sometimes people sell a bound one, but when you can print them, I don't know why you'd want to do that. But the cost is probably higher to buy something that somebody else is selling. And you want to make sure that they're the official guidelines. They have to be the official guidelines. So, and I do believe it says that on the AAPC website as well. So, you know, when in doubt, print that off and bring it too. And I can say, being a proctor, I hear so many stories when people come to do a second test or another certification about their experiences at a last place that they did. And we do try and give thorough, we do receive training, but if people don't show up for the training or do the training, then you know, you're kind of stuck. So hopefully if you have a question, have that proctor please ask the emergency contact person or have them look it up. So, you know,
and so that
good
means
to
you need
arrive
get there
early.
early.
Yeah.
Get there early.
Yeah,
Don't
arrive
walk
early
in
so you have time
5
for
minutes
that. Yeah.
before and then say, well, you need to call the 800 number. Well, you should have gotten here earlier. You know, because you can't stop it for everybody just because. Yeah, I wouldn't get it bound. I don't know how many pages is it. It's like
it's a lot. It's a
I think
lot.
1 year it was 117 pages, and
yeah, I mean, in your book it's maybe 25, but that font is this big, you know, so, and it's on 4 columns. So when you print it, it's going to be 4 times that. So yeah.
CPC versus the CCS in a private practice. Is one better than the other when doing both coding and billing? Well, the CCS is geared more towards inpatient. CPC is anywhere provider practices, but it's mostly known for outpatient because there are no inpatient, you know, questions on the CPC as far as there's no ICD-10 PCS. And you're definitely going to have PCS on the CCS because it's an inpatient credential. So
is that inpatient? CCS?
I thought CCS was is it not? Is it not?
Is that CCS?
I thought I thought the CCS had inpatient. I mean, it had PCS on it. I haven't taken it.
Oh, hospital, medical providers, CCS to insurance companies or the government. Okay, yeah, I haven't done my HEMA yet. I am not that familiar with the HEMA. I have to because my school's credentialed with a HEMA and I teach there, so I have to I have to hold in a HEMA certification too. I just haven't done it yet because I have to finish my other 2 by the end of the year. So
now the CPC is a proctored exam. It's paper exam. The CCS is an electronic exam. You'll go to a testing center, and you can't take anything with you except for your manuals, and they cannot be written in.
Your manuals can have nothing written in them, no highlighting, nothing. So I'm going to have to borrow somebody's.
I know.
Mine are all written up.
Because I was thinking about taking the CCS, and I put so many notes in my PCS manual, and it's like, oh man, I'm just going to wait for the 2020.
Yeah, take it when you have brand new books before.
Because I want my notes. So when I take it, then I'm going to put my notes in.
A practitioner's tested data quality and integrity skills. I'm not sure.
Private practice, I don't think it's gonna. It's really not gonna matter per se. The CCS has been around.
CCSP is your physician base.
Yes.
Yeah, that's right. Yeah.
And so private practice is usually a specialty. Not always. I mean, but still, even family practice has a specialty, like we know now it has a credential. So a CPC is pretty broad, and don't think of it as where you work. Think of the code sets that they use. So with the CPC, you're going to be tested on the ICD-10, CPT, and HCPCS, and that's it. All right. With the CCS, though, it's going to be ICD-10. It's going to be ICD-10 PCS, and there is CPT on it, where, you know, if you're taking the CIC, which is the credential for inpatient for the AAPC, there is only ICD-10 and ICD-10 PCS. So, you know, I would say find out what most people in your area have and go with that.
Mm-hmm.
But just keep in mind, HEMA has been around since the 1920s, very well known, mostly known for inpatient, but now they have other credentials. And AAPC has been around since the 80s, and they're mostly known for specialty credentials and outpatient, but they do have multiple, they've branched out since then. So now I looked up these codes. I just wanted you to know ahead of time.
Oh, I was working on it, and
Were you?
Whitney posted the question
Did she?
right before I started talking. So then I
Oh.
did my thing, and then I meant to go back and see if she, got the answer for it. But yeah, I
Well,
didn't. What'd you find?
The key is that Jesus sent me a note and said, "Can you
Oh,
answer this question?"
fine.
Yeah. And I thought Jennifer's going to see this and she's going to jump on it because it's mental health and she's been working on that. So how long does a patient have to have depression in order to classify as chronic depression? Would you use F32.9 or F33.9 for chronic depression? Well, I went ahead and my slow computer just pulled up real quick so you could see. F32.9, major depressive disorder, but it's a single episode, unspecified. All right. So this is your catch-all. If it just says depression, if it says major depression or depressive disorder, this is the code you use, right? However, this code, the other code that was mentioned, major depressive disorder, recurrent unspecified, or monopolar depression, not otherwise specified. Here's the key, and Find a Code had this for us. If they are an MDD, because nobody says major depressive disorder, then it explains what it is, and then it says all of the following must be met. The depressive episode lasts a minimum of 2 weeks.
Mm-hmm.
The cause is significant problems at school, home, occupation, or social situations. There has never been a hypomanic or manic episode. Now, signs and symptoms and everything, you don't really need that per se, because in other words, you would need to know that you don't code for these. However, you can't make the diagnosis. All right. So then we have here where it says severity. So we have mild, moderate, severe, and then it says partial remission and full remission. Okay. So there is specificity for that. However, notice that your person, they didn't ask us that. So let me just move this out. It says, how do I know if it's chronic depression? All right. Now, the first thing you need to ask yourself is, what does the documentation tell you? Because you cannot code something chronic if the provider has not given you information to allow you to do that. Now, they may have not said it's chronic depression, but they stated that the person had, and then it comes over here and says up here, this has all been documented. Okay. So again, if you have someone that is meets this criteria, and let's see, significant number of symptoms, remission, history of previous MDD, current episode, symptoms are present, but full criteria are currently not met, at less than 2 months without significant symptoms of MDM, or full remission, again, history, and has no symptoms for the last 2 months. So 2 months is it for remission, but for episodes that last a minimum of 2 weeks. Okay, those are your things. What do you think? Do you have other things to add to that, Jennifer?
No,
know
and actually that person that I told you I consult with, I just talked to her this week, and this actually came up. And so that's why I was like, oh, where's that information again? So I send her so many links and stuff. I always have to, it takes me a while to find them. But, it's like that. I know I've seen something where did I see it and what was it? But I knew there was that, yeah, the 2 weeks, it has to happen like every day. It has to be certain, you know, there's certain criteria for it. Because we were talking about the depression screening.
Right.
So I came up with that because I guess apparently her coders, her staff all wants to build a depression screening now. And I said, well, I did a webinar on that last year. Let me look up the information.
Yeah, I get you that information.
I remember doing that last year. So yeah.
The fact is you are stuck with the F32.9 unless you have the documentation, and honestly, you need to have a conversation with the provider. So it says, okay, I need to have them educate you on what they say chronic depression is. What's their criteria for an F33.9? Okay, and then have that written down, put it in your compliance notebook, and then you know you're not going to have somebody come back behind you and say, well, that's not really, that's an F32, not an F33, or, you know, how come you didn't code the F33 when it was, you know. And so have that conversation, and providers love to educate us. And so say, you know, can you help me understand how you would document the F33 or the F32.9 versus an F33.9 so that I'm always on the same page with you. That's what I would do too. And I think that's it. So we've mentioned YouTube a lot tonight, at least I have. Go to our Medical Coding Cert YouTube channel. Then what you do is you click subscribe. If you click subscribe, you're going to get information about videos that we do. If you want a heads up, you can click a little bell that's not shown here because it's a relatively newer thing. Click the bell and it will literally pop up and tell you, hey, CCO is doing a live event right now. And you can put comments in there. Feel free to share our videos if you feel that they've been helpful. That helps us. And the more comments you make in the videos, that also helps us. And we are at almost 25,000 subscribers, and we have over 1,200 videos in our YouTube. Now, that being said, if you are frequent on YouTube, you're probably frequent Facebook also. Real easy to find our Facebook page because you just go to Facebook, put the /CCO.US, and then you'll get us. Make sure that you like us, and they've got a notification also to, you can say, hey, I want to know every time you're going to go on Facebook Live, because we do events, and sometimes I just pop up and do a little Facebook Live, like after the Dallas Central, when I did one for just a few minutes and said, oh, it was so much fun. So again, do that, and then share the information, make comments. We want to know if it's helpful to you. Being said about the local chapter, Jennifer and I love to present, and she's willing to go and present at your chapter if it's feasible for her to get there. But she's over in by DC. What you're in?
I'm in Southern Maryland, so pretty
Maryland,
much
yeah.
anywhere from South North Carolina all the way over to Virginia, you know, other side of Virginia, West Virginia, Pennsylvania, Delaware. Yeah, I mean that's all a couple-hour drive. You know,
Yeah,
it's not that bad.
I used to live there. Just thinking about that tires me being on the beltway and stuff.
I was in Boyd's neighborhood a couple weeks ago, and I didn't even come
Yeah.
say hi.
Oh, that's all right. I get it.
and I'm in Texas, and I'm smack dab in the middle of Texas. So everything is 2 to 4 hours away from us. You know, so anybody that Texas, Louisiana, I might even go up to Oklahoma and drive up there. But one time we went to Johnson City, Tennessee. My husband and I took off and did a lecture over there. It was a lot of fun. So if you want us to come personally, we're willing to do that. But if you don't want us to come personally, we can do remote presentations. We can do them live, or we have a lot of pre-recorded ones that everybody has enjoyed.
If anybody has been at one of our presentations who's on the webinar tonight, we'd like to hear a comment from you, and even send us a picture if you have one, because we'd love to get your pictures.
The Dallas ladies, she took several pictures and she said she'd send them to me. So I'll get those to us and we'll put them up on our Facebook page. All right. Don't forget to take that survey. That truly does help us. We want to get the pulse of you, what you desire for us to talk about. And the CCO.US/club. Don't forget there. And here is a whole bunch of other reference links that you can go to. We have a testimonial page and all kinds of things here.
And again, this is in the handouts that's in your GoToWebinar control panel that you can get right now before we end the webinar.
And I think that's it.
Ta-da, there's the team.
Oh, Alicia's got a new picture on there. Yay.
I did, because my hair's gotten longer. I asked Boyd, I was like, can we put a new picture? In fact, I told Jesus on our About page that, it tells a little bit about us. And I was looking at that the other day and I was like, oh my, I am over 30 years in the medical field now. So he updated it. It had said 20. So.
Yeah.
I don't have a new hairstyle, but I do have an old headset. I think this is from my original headset, so it's gone through, it actually broke off, so I was like reusing it, just as a backup. Now it's become my main headset. So
that's funny.
Yeah, no hair,
right.
but headsets.
Us women, we changed. Laureen is practically blonde, toe-headed now.
Yeah.
Being in Florida, she's gotten her hair much lighter.
Yep.
All right, guys, I think that was the last slide. So
Sayonara.
yeah, don't forget, like and subscribe out on YouTube and Facebook, and let us know what we can help you with.
See, Jennifer, did you get her sign off? She does that really well. That's how I know that the end is. Sometimes Jennifer ends a webinar and she kind of goes, ends a sentence and then it's done, and I don't know when it ends. We got to work on your ending line. Do you want to try one tonight?
Me?
Yeah. What would you say there?
Oh, I know. She's going to say, live long and prosper. You guys
So
don't
may
know
the
this.
force be with you.
I was going to say, Star Trek and Star Wars, she is right there. Yeah, you're right. May the force be.
Yeah, we're not going to talk about tattoos. Don't worry about that right now. Okay? All right, everybody. Thank you for being with us again. And until then, happy learning, as it says on the screen.
See ya.
Bye. And I want to make sure I do this first.